Welcome to the lecture of urolithiasis, and we'll be discussing about the basics of urinary system stone disease now. See, urinary system disease is one of the oldest disease affecting the mankind, and the most commonly it affects the kidney, upper part of the urinary system. If you see the prevalence, it is around 1 to 20% throughout the world, depending on the geographical condition, climate, the dietary factor, and all the genetic factors. And if you see the incidence nowadays, the stone disease is increasing worldwide. The size may vary from very small, few millimeter, sand-like stone, up to very large, multiple branching stag on stone. Size varies. Okay, and the most common symptoms or presentation of a patient with urinary tract stone disease is pain, and which is usually associated with hematuria. Okay, which is usually associated with hematuria. Let us talk about some etiology or predisposing factor of stone disease. Basically, it is a multifactorial disease where a lot of factors come into play. Okay, uh, if you see, the male has a higher chance of getting stone disease than female, about 2 to 3 times higher. But nowadays, the incidence of you know, increased male incidence is narrowing. That is, females are also having more stone disease nowadays. If you see the race and ethnicity, it is more common along the white population, 4 to 5 times, followed by Hispanic and Asian Africans. Okay. This difference in the race may be due to genetic makeup as well as the dietary habit that we have. The Western diet has a higher tendency of making stone due to more fatty, more protein diet, as well as diet making a person obese. Okay, that's why it's more common along the white population. Obviously, the geography of climate, the hot and dry climate is more responsible for the stone formation because it lead to it lead to dehydration, and dehydration lead to super saturation of urine, and which lead to stone formation. Obesity is one of the problem, okay, nowadays in the world, and this obesity is also a risk factor for stone disease. Whenever the BMI is more than 30 kilogram per meter square, then the risk increases. And those who have the higher BMI, they have increased, excretion of oxalate, uric acid, and phosphate in urine, leading to higher chance of formation of oxalic acid, uric acid, and phosphate stones in urine. As I have already told you, dehydration has a very directly role in stone formation. It leads to supersaturation of urine. There are some urinary disease. Okay, basically any disease that causes a stasis. Stasis means decrease in flow of urine. That can lead to stone formation. And suppose, for example, there is a this is the kidney. Okay, this is the kidney. You can see over there. Suppose there is a obstruction of urinary flow due to narrowing at PUJ, just allowing little urine to go down, but more the urine will stay here in the pelvic calcial system, and this lead to the stasis, and stasis lead to supersaturation of urine and can start precipitation of stone. So any obstructive uropathy, basically the bladder outer obstruction or a urinary flow like PUJ or VUJ obstruction, these can cause the stone formation more common. If you see, one of the most common cause of the bladder outer obstruction is BPH in old age. So in the case of BPH, it may lead to decreased urinary flow, and that decreased urinary flow may lead to stasis, that is, post void residue of urine, and from here it can lead to the stone formation as well. So see, any obstructive uropathy, obstruction in the urinary flow, can lead to stone formation. Similarly, similarly, the UTI. Okay, UTI. It's very important in stone formation. Basically, whenever there is infection of the urine by a urea splitting bacteria like protease, what they do is they break the urea, they split the urea into ammonium compound. Okay? The urea is split into ammonium compound by bacteria, that is mainly protease. Okay, the protease, that is urea splitting bacteria. The bacterial enzyme urease break the urea into ammonium compound such that the pH of urine will be increased, and whenever the pH is more than 7.2, then it leads to stone crystallization, and that stone is true white stone, also known as magnesium ammonium phosphate stone. So UTI has a direct role in formation of stone because it alter the pH of urine. Okay. Similarly, one more thing I have to say you that the UTI can cause stone, and the vice versa is also true. The stone can cause UTI as well. That's why the urine culture is very important because I've already told you the UTI may cause stone, so we can identify the protease or other urea splitting bacteria, and we can manage accordingly. Or the stone disease can be associated with UTI. So these things are very important. Okay. See, those patients who have a we had a history of stone can have stone in future as well. So you can see over here, around 35 to 75% of patient will develop stone in 10 years. Okay, that is, it is very recurrent disease because maybe the factor that is associated with the stone formation is still there. Okay, it is not removed. That's why. And that's why after the surgery of stone or stone removal, the most common, the most important point is we must focus on prevention of stone. So how to prevent a stone? There are some general guidelines. There are some specific guidelines. Okay, I'll explain later on. So this is very important. We don't want the patient to suffer by stone disease multiple times. Systemic disease, the the diabetes. Okay, the patient who are diabetic, they are especially type 2 diabetes. This patient have a higher chance of hypercalciuria, that is they excrete more calcium into the urine, as well as the pH become more acidic, which lead to the formation of some specific stone like calcium stones. Okay, vitamin A deficiency. If you remember our basic physiology, then we know that vitamin A is essential for maintenance of the epithelium of the entire body, not only the immune system. And we know the epithelium of the immune system is known as urothelium. Okay. Whenever there is a lack of vitamin A in the body, then it lead to desquamation. Desquamation means the epithelial cell fall down, they are desquamated, and they can acts as nidus. Nidus means one point of attachment where the crystals like calcium, oxalate, urate, phosphate, they get attached around this nidus and can form stone. That's why the vitamin A deficiency lead to desquamation of epithelium, mainly urothelium, and then acts as nidus, which helps to attract other crystals and may lead to the stone formation. This is very commonly found in the children. And if you see, the another cause is hyperparathyroidism. Okay, hyperparathyroidism means excess release of parathyroid hormone. And if you know that the normal function of parathyroid hormone is to increase the calcium level in the blood by absorption from the bone. So whenever there is excess secretion of the parathyroid hormone by the parathyroid gland, maybe due to adenoma, then it lead to excessive calcium formation as well as excretion into the urine, and it lead to hypercalciuria, as well as it causes increased excretion of phosphate in the urine, leading to the calcium phosphate stone more commonly in the urine. Okay, so and whenever there is a recurrence of stone disease in any patient, especially calcium containing stones, then we always check for the hyperparathyroidism. Okay, because this is one of the cause of recurrence of stone. See, there are some metabolic situation, okay, where uh, it lead to the stone formation. Okay. See this first and second, hypercalcemia and hypercalciuria, they are very closely related. Hypercalcemia means excess calcium in the blood. Hypercalciuria means excessive calcium in the urine. Okay, so these conditions can be caused by either increased absorption of calcium from GIT, or due to you know, hyperparathyroidism, where there is an increased calcium excretion and phosphate excretion in the urine, as well as there may be some condition where the calcium which should be reabsorbed by kidney is not reabsorbed and lead to hypercalciuria. So in all of these three cases, it lead to excessive calcium inside the urine, and that lead to crystallization of calcium along with other ions, forming calcium stones. Hyperoxaluria means excessive oxalic acid in urine. Okay, basically it can be due to primary or genetic defect of metabolism, or maybe secondary cause. The primary cause is more common than secondary cause, and in secondary cause it is usually associated with the diet means some food contains more oxalic acid, like spinach, tea, chocolate, all those things contains more um, oxalate. Okay, and whoever it in excess of these things can lead to hyperoxaluria. And also excessive vitamin C intake can also lead to conversion of these into the oxalic acid and lead to hyperoxaluria. That's why excessive calcium consumption is not advocated. As well as if the patient, if any person restrict severe restriction of calcium in their diet, then the restriction of calcium promote the oxalic acid urine formation, so hyperoxaluria, leading to oxalic stone formation. That's why excessive restriction of calcium is also not advocated. It may lead to oxalic stone formation. Okay. Hyperuricuria means excessive uric acid inside the urine, and the uric acid is basically metabolites of purines, or protein metabolites. So this hyperuricuria may be due to the genetic defect, okay, like in the case of gout, or it may be due to the excessive consumption of the animal protein. So, or maybe some disease condition where there is excessive turnover of the cell, leading to excessive breakdown of nucleic acid and lead to the uric acid formation. In any of situation, whenever there is an excess uric acid formation inside the urine, it may lead to the crystallization of uric acid and lead to uric acid stone. Okay, and this stone must need acidic pH less than 5.5 to make a crystal of stone. Okay, stone formation. Cystinuria is a genetic abnormality where it's purely genetic abnormality. It's not common disease. Okay, wherever there's an excess of cystine in the urine. See, in all situations you have seen the excess in the urine, but one situation here it is that hypo means less. Okay, so hypositraturia is a condition where there is a lack of citrate in urine. Okay, see, the citrate is a natural inhibitor of a stone formation. Basically, it decreases in the formation of calcium oxalate and phosphate and urate stones. So whenever there is a lack of citrate in urine, and that may lead to the stone formation. Basically, mainly oxalate, phosphate, and urate stones are more commonly found in hypositraturia. So these knowledge of a metabolic cause can be utilized later on during our prevention part. Okay, so I'll again revise this thing later on in prevention part, how to use this knowledge later on. So now what we can conclude is, um, there are various factors which play a role to make a stone, and not all the factors are present at once in each and every patient. Some patient might be just obese, and the BMI, excessive weight or obesity may be the cause. Wherever, sometime in other patient, that might be just they're working outside in a very hot and dry climate, not drinking adequate water, and that might be causing stone formation. Whereas in some patient, there might be a anatomical abnormality like obstruction in the urinary tract, or maybe some might have metabolic disorders. So there may be a combination of multiple cause, or there may be a cause in different patient. That's why we have to treat each and every individual of stone disease in different way. So basically, treatment means first we remove the stone, then the real treatment start, that is prevention. That's why for these all things we need to know about the etiology or predisposing factor. Now let us discuss about the the pathogenesis. Okay, I'll be just discussing in very brief. Okay, see, uh, the stone, the basic mechanism of stone formation is the urine must be supersaturated. Supersaturated means the urine contains water and the electrolytes. Okay, a lot of electrolytes inside the urine. And whenever the concentration of electrolytes are more than the concentration of water, that means the water inside the urine is unable to dissolve the electrolytes, then the precipitation of the electrolyte starts. Okay, okay. This is just, we can I can explain by a very very common example that we have learned in our school life. That is, uh, suppose this is a glass of water. Okay, if you start adding the salt in this water, then initially the salt will dissolve. Okay, the salt will dissolve, and you will keep on adding the salt. Okay, fine. Against it will dissolve, but there will be a point of time when you if you add a little of the salt, then the salt doesn't dissolve, it start to precipitate. That point is known as supersaturation. So whenever you add an excess of solute or a electrolyte or a salt beyond the capability of the solute to dissolve it, then it will start to precipitate. That's why whenever the liquid gets supersaturated, the solute start to precipitate. And the same thing happen in urinary tract as well. Whenever there's an excess of electrolytes, or a stone forming agent, then the water that is usually making it soluble, then stone start to form. Plus, these process needs some additional help. Okay, for example, in our urine we have very delicate balance of a stone forming agent. Okay, stone forming agent which are always trying to form the stone, like the electrolytes like calcium, phosphate, oxalate, urate, all those things, as well as we have the agent in our urine naturally found, which always try to prevent the stone formation. These are known as inhibitors like citrate, magnesium, and pyrophosphate. There is always a balance between these two, and as well as we have a lot of urine or water that always want to dissolve the solute. So solutes that want to make a stone, the inhibitors that want to prevent the stone, and the water that always want to dissolve the electrolytes. So there is a delicate balance between these three components which always prevent the stone formation. But whenever this balance is disturbed, either by excess of electrolyte, like increased calcium level in the urine or oxalate level in the urine, due to any cause, in that scenario, or in the same time, there might be condition where when the inhibitors may be decreased, like citrate is decreased. Okay, or whenever this water part, that is there's a lack of water in the urine, that is due to dehydration. Okay, dehydration. So in any scenario, whenever this delicate balance is is altered, then it lead to the stone formation. Okay, so let's see. So we have three factors basically: the supersaturation of urine, then precipitation, then lack of inhibitors. So I've already explained everything. Let us see in the flow chart. Okay, see over here, the excess of stone forming substance like calcium and oxalate. These, whenever there's an excess of these things, um, then it leads to supersaturation of the liquid. Okay, and whenever there is supersaturation of liquid, uh, added by the factor, the lack of electrolyte, sometimes the lack of inhibitors, or maybe sometimes the dehydration also. Okay, dehydration. These all lead to formation of the crystal. Once the once there is a supersaturated urine, it start to crystallize. Okay, it start to form the stone, and once that starting of the crystal formed, known as nucleus, then the other stone, that is the other part, other crystal, tries to form around it. Okay, trying to form around it. That means there's a aggregation of crystals around the nucleus, and they grow in size slowly and slowly and slowly. They grow in size. Okay, so this is the basic mechanism. Let me explain one more thing. You may say then the stones are very small at the beginning, so every time the urine is flowing, okay, so why not the small stone 1 or 2 millimeter that is formed at the beginning, why not it is flushed out? Yes, it is possible. That's why there's a theory that there must be a anchoring site. Okay, so you can see the picture at the top right, that is internal picture of the calyx of the kidney. You can see this yellow spot over there. Actually are these are the atherosclerotic plaque, that means fatty plaque, found at the vasa recta, or the vessels of the papilla. These fatty these fatty spots, which are the atherosclerotic or the fatty spot inside the vessels of the papilla, vasa recta, allow the anchoring point for these small crystals. So these small crystals get attached to these atherosclerotic plaque, also known as Randall's plaque, and which allows the crystals, the nucleus, the beginning point, it allows this crystal to get attached for a while, and later on, the remaining other crystals forms the stone around the nucleus. So this is the theory that this Randall's plaque in the inside the papilla, it helps to form the stone. So this is stone formation in summary. Okay, I hope you guys understand. Composition of stone. Basically, stone is formed of two things, that is stone crystals and matrix. Okay, the crystals means is the most commonly it contains crystals. Matrix is the sum, around 2 to 10% of the stone volume contains the protein glycoproteins. Okay, and around that it forms the stone. Okay, mainly the crystals that is formed around these, crystals are found. Okay, so basically, around 90 to 98% of the volume of the stone is made up of crystals, and around 2 to 10% is made up of proteins, protein material. And crystal means it contains the same calcium, oxalate, phosphate, all those things. You can see over there, crystals. Okay, so this is the basics. Let us study about the types of stone. This is important. Types are always important for the management point of view. That's why classifications are always important. Remember these things. We can classify stone in various ways. The stone can be classified according to composition. That means the crystals, type of crystals, according to the plain X-ray characteristics, according to etiology, and according to the stone location. Okay, these are the common way to classify. So let me finish the last one first. Okay, the location. So why we need to know the stone location? We can just say kidney stone, we can just say ureteric stone, we can say bladder stone. That's enough, but not enough, because whenever you diagnose the stone, we always want to manage it. Okay, so let me give an example. Suppose there's a stone inside the kidney. Inside the kidney, okay, and that stone is suppose uh, at the calyx of the kidney. Okay, so suppose this we're drawing over that is the kidney. Okay, so it is over here, like here. It is found over here. Okay, so see, this stone is lying, locating at the lower calyx. So what's the importance of knowing the exact site of this stone? So if you know the exact site of stone, suppose the stone size is around uh, 2.5 or 3 centimeter, a large stone, suppose. And in that scenario, what we can do is, now in the large stone, which is around more than 2 centimeter, occupying the lower calyx, for this patient, our approach would be PCNL, that is puncturing the lower calyx, going inside, breaking the stone, and bringing it out. PCNL. I'll discuss this thing later on in detail. Suppose the same thing here. The stone is there, and the stone is not big. Okay, suppose it is hardly 1 centimeter stone and lying at the lower calyx here. Suppose, okay, and this stone now being a small stone and lying at the lower calyx, what we can now plan is we can do the ESWL. That is, we can apply the shock wave from the external point, and we can damage just break the stone and just bring it out. Or we can go through the ureter, and we can break the stone by a laser known as RIRS. So see, the location is important. Okay. Similarly, let us give an example of a ureteric stone. Okay, you can see over here. So this is the ureter here. Ureter. We divide the ureter into three part: upper, mid, and lower part radiologically. So suppose a patient has a stone at the upper ureter. Okay, over here. Okay, and another patient has a stone in the lower ureter. Okay, so the approach for these two patients will be different, right? So see, for the patient who have a stone in the lower ureter, the best option would be going from the below and breaking the stone and take it out. That is URS, ureteroscopy, right? Where we go inside the ureter, break the stone, and bring it out. But as the stone is upside here, the options would be different. Okay, we can use the shock wave ESWL from outside to break the stone, or we can we can just go from the below, and we can break the stone by URS, or we can push it back inside the kidney, and we can break it by PCNN or ESWL. So see, the location of stone give us idea how to manage it. That's why location is always important. Okay. Now let us discuss the other uh, classification, that is composition. Okay, so see, according to composition of a matrix, that is, sorry, of a crystal, we can divide the stone into basically two types, that is uh, calcium containing stone and non-calcium stone. Most of the stones are calcium containing stone, around 80 to 85, some say around 75 plus, doesn't matter. uh, the stone Most of the stones are calcium containing stones, and among that the most common stone is calcium oxalate stone. Okay, and see, in the non-calcium stones, we have all the other stones that are not made up of calcium. That is uric acid stone, magnesium ammonium phosphate, also known as struvite, cysteine and xanthine stones. These are genetic stones, and drug stones like silicate in navi and these drugs. So these are the example of calcium and non-calcium. Is it important to know this differentiation? Yes, because the calcium stone behaves in one way and non-calcium stones behave in other way, and the causes are also different. That's why it is better to know the calcium and non-calcium stones in this way as well. Let us see some examples of calcium stone of this composition. The calcium oxide stone is one of the most common stones, and these stones have very sharp edges. The sharp surfaces. The surface is not smooth. Okay, it is spiky oxalic acid, sharp uh, surfaces, and this is good for the patient because once the stone moves, it causes hematuria. And whenever there's a pain and hematuria both at once, then patient will not stay at home and they will just come to the doctor. And that's why these stones are diagnosed in very early stage, such that it prevents the renal damage. And sometimes the stone is covered by the very clot due to excessive hemorrhage. It can be seen like this as well. And see, the more important one is all the calcium stones are radio opaque stones. That means you can see these stones in plain X-ray KUV. And the stone is important is struvite stone. The struvite stone means basically it is composed of magnesium ammonium phosphate. Magnesium ammonium phosphate is known as struvite stone. And if the struvite stone contain additional calcium, that is calcium, magnesium, ammonium phosphate, also known as triple phosphate. So don't get confused. Whenever the magnesium, ammonium, and phosphate stone, that is struvite stone, um, has additional calcium, then it is known as triple phosphate. These are the surface are very smooth in compared to the oxide stone, and it looks dirty white in color. And the very important thing is these stones are formed in infected urine. Infected urine, when the pH is increased to 7.2. We all know that the normal pH is acidic, but here whenever the pH is increased and reaches more than 7.2, then only this type of stone can be formed. Okay, then how the pH is increased? The pH is increased by the urea splitting organism, okay, like protease. Okay, so whenever there's whenever there's infection by these organisms, then the urea inside the urine is splitted into ammonium compound, and this ammonium compound, ammonia, causes the increase in pH. Increase in pH. Okay, so whenever there's increase in pH, whenever the pH is more than 7.2, then it is enough to crystallize these this salt like magnesium, ammonium, and phosphate, and can form the stone. Okay. So the common organism is Proteus. There may be Pseudomonas, Providencia, Klebsiella, Staphylococcus, and other. The most common is Proteus. And see, as this stone is smooth and doesn't produce symptom that much, so it can grow slowly and slowly and slowly, and can fill the entire uh, pelvic calyceal system. And whenever it fills the pelvic calyceal system, then it looks like the horn of deer. That's why it is also known as staghorn stone. That is when the struvite stone covers the pelvic calcium system and forms the branching stone that looks like a horn of deer, then it is known as staghorn stone. Okay, staghorn stone. So struvite stone is the most common type of staghorn stone. Other crystal can also form staghorn stone, but struvite is the most common chemical composition of staghorn stone. See, it can form the stone. It can fill the calcium system slowly and slowly and slowly, and can form the staghorn stone. As I already told you, these are very smooth in compared to oxalate, and that can cause the mm, that might not cause any symptoms for years and years. That's why it's also regarded as silent stone sometime. And though they don't have calcium normally, still they can be seen by X-ray, but it is poorly radio opaque, not as white as other calcium containing stones. Okay. Okay, staghorn stone. Staghorn, I've already told you what staghorn means. Whenever there is a multiple branching stones, then it's known as staghorn stone because it looked like the horn of deer. Okay, that's why we compare that with the horn of deer, and that's why it looked like that way. That's why we say staghorn. Basically, this is the plain X-ray QB. This is not an eye view. This is a plain X-ray QB. You can see the stone is completely occupying the calcium system as well as the pelvis and forming the staghorn stone. And the most common chemical composition of staghorn stone is struvite stone. Okay, and the stone is uric acid stone. Okay, this is around 5 to 10% of urinary stone. Okay, and these are multifaceted stones, not spiky as oxalate. They are common in the condition where whenever there is a excessive uric acid production in the urine, that is hyperuricosuriia, like in the case of gout, myeloproliferative disorder, or those who are treated with the malignant condition where the cell turnover is increased, and whenever there is an increased cell turnover, that lead to the breakdown of nucleic acid, and that leads to formation of uric acid. Okay. And the very crucial criteria is the pH should be less than 5.5. If the pH is more than that, these uric acid are never crystallized. This knowledge is very essential. Later on, we can apply that knowledge during our prevention part. That is, if we can make the stone urine alkaline, then the stone formation will be decreased. Okay, that's why this knowledge is important. Remember that. Okay. And one more important thing is this stone is actually radiolucent. That is, this cannot be seen by plain X-ray KUB. Okay. So how to see it? I'll tell you later on. So uric acid stone is a radiolucent stone. Remember that. Okay, let us classify the stone according to the plain X-ray characteristics. Okay, that means some stone can be seen, some stone cannot be seen by the X-ray. So those stones which contain calcium, like calcium oxalate and phosphate, they are very brightly white, okay, in plain X-ray. That's why they are known as radio opaque stone. Other stone, though they don't have calcium, they can still be seen by plain X-ray, and they are not as white as calcium stone, but still they can be seen. That's why it is known as poorly radio opaque. Still can be seen in X-ray. But there are some stones which cannot be seen in our plain X-ray KUB, and these are known as radiolucent stone. Okay. And the most common cause is uric acid stone, like a xanthine stone, and the drugs that I have told you, drugs cannot be seen, like silicate, indinavir. So these are the common one. Silicate is found actually in our antacid. Okay, antacid containing silicates. If the person take more antacid, okay, due to peptic ulcer disease containing silicate, that can get precipitate in the urinary tract. Also, the patient which HIV/AIDS patient taking indinavir drug for a long time, then that can also precipitate inside the urinary system. So these drugs are precipitated if taken in long time or excess. And these stones are radiolucent stone. Radiolucent stone. Cannot be seen by the plain X-ray KUB. Let me show you some of the pictures. Okay. See, this is the plain X-ray KUB. I have already taught you how to count the vertebrae. So this is the sacrum. Okay. Just above it is number 5, it is number 4, number 3, 2, and 1. Okay, we can go this way. You can go from above downward or below up. I prefer from below up. Okay, so so how we can describe it? There is a radiopaque shadow which is elongated. Okay, at the level of number 4th vertebra, in the left side along the paravertebral region. So see, this is very clearly seen a radiopaque shadow. So this must be a calcium stone. It's very bright radiopaque shadow. Okay. See, I have the picture here. Still, there is a radiopaque shadow which can be seen. Okay, and most probably number 5, number 4 vertebra around. So this is a elongated radiopaque shadow. Okay, here this shadow is not as bright as this shadow in the left picture. Still, it is radiopaque. So, so this is still a radiopaque stone, but it is poorly radiopaque. Might be strawberry stone. Okay, we have to check it later on by chemical analysis, stone analysis. Okay. See another picture. Suppose a patient, 25 years old male, complain to you that he has a pain in the back area, and the pain is radiating left back, okay, along the left flank, and the pain is radiating downwards to the scrotum on the left side. If he said that, and he also said that the pain is associated with hematuria. This is the very typical classical picture of stone disease in urinary tract. Basically the ureter, because it is going downward, radiating downward. And you ordered for a plain X-ray QB, and you found nothing. In this picture, you can just see the normal lumbar vertebrae, the ribs, the pelvic bones, the sacrum, the muscle shadow, but not any radio effect shadow. That means the patient is not lying, because sometimes the patient might have the radiopaque stones. Okay, so whenever the clinical scenario is strongly suggesting it is a case of stone disease, but the plain X-ray is not giving you the picture of the stone, that time what to do? That time either you go for a non-contrast CT scan, or you can go for an ultrasonogram KUB. Better go for a non-contrast CT scan. Same patient, the non-contrast CT scan is now showing you the hyperdense, that is whitish structure in the upper ureter. Okay, so see, patient where we cannot see anything in the plain X-ray QB, but we can see the stone in the non-contrast CT scan. That's why these type of stones are known as radiolucent stone, because they were not seen by plain X-ray QB. But these radiolucent stone can be diagnosed by non-contrast CT scan as well as ultrasonogram. Okay. So another way to classify the stone is etiology. So that is non-infectious means not associated infection. Infectious means most common infection stone is strawberry stone, that is magnesium ammonium phosphate stone. Other stones like carbonate and ammonium are also there. Genetic cause, I've already told you, cystine and xanthine are purely a genetic disorder where it's very rare stone. Okay, and the drug stone, I've already told you, the most common are silicate and the Indian heavy drugs. This can also precipitate. Sometimes, if you see a vitamin C is also a drug, the excessive consumption of vitamin C can also form the stone. But this is a bit different. Okay, mainly the drug like the silicate and Indian heavy, prolonged consumption can cause the precipitation. So this is the way how we can classify the stone. Okay, according to cause. Okay, so we have finished till now the basics of stone, that is pathogenesis, the different types in different classification on. Now let us study the diagnosis of stone disease. Okay, so see, to diagnose any disease, we must follow the clinical feature and the investigation. Clinical feature I'll discuss later on whenever I teach you the specific chapter. Now I'll be more focusing on the investigation that we commonly do for the stone disease. Whenever we suspect a patient has stone disease, we follow a similar pattern of investigation. Okay, let's see what are those. See, most commonly, part of the investigation we do are uh, urine routine, okay, and culture, renal function. These are commonly done for each and every patient. Plain X-ray, KOB, and ultrasonogram. Okay, if you follow a very basic way of investigation, then these four are the very common investigation that we do at the beginning. Okay, and after knowing there's a stone disease and so on, later on we do either IVU or non-contrast CT scan for the detailed information required for the management. Okay, so this is the one approach of investigating the stone disease. Okay, most commonly followed in the country where the resources are very limited and very expensive tests are very difficult to do. So what we follow is a urine culture, renal function test, plain X-ray QB, and ultrasound QB at the beginning one. screening test, you can say, followed by, if you see the stone there, then we can do either IV or CT scan, non-contrast CT scan of QB region, to get a detailed idea about the stone for the management. This is the one way. Another way is, okay, you in routine and culture and renal function, you do it. Okay, this is the very common one. Then you can directly jump into non-contrast CT scan. This is the best investigation for stone disease. Okay, you can do that as well. So depending on the resources and the protocol of your country, but still the very basic way is to do the first 1, 2, 3, 4 test, and then you go for IV or CT scan non-contrast for for detail knowledge of stone disease for the management. Okay, let us discuss these things in one by one. Urine routine. We all know what is urine routine. I'll be just focusing on the point required for the stone disease. Okay, see, pulses. Pulses more than six are significant, and I've already told you the stone is associated with UTI, and UTI is associated with stone. That's why there might be excess of pus in urine, and one of the most common symptom is hematuria. So more often we find hematuria, that is RBC, inside the urine. Okay, more than three are significant. pH is important. Don't ignore the pH, because I've already told you the crystallization of electrolytes depend on the pH of urine. If some crystals get precipitated in some pH, where other get precipitated in other pH. For example, the struvite, that is magnesium ammonium phosphate, get crystallized or precipitated only when the pH is more than 7.2, whereas other stone like oxalate, cystine, and uric acid stone, they need acidic pH. Mainly the cystine stone, if the pH is less than 5.5, then only they can crystallize. And this is very important. That's why you should know the pH. And one more thing, one extra benefit is that if you know the pH of urine, and if you know the type of stone later on by analysis, then you can reverse the pH to prevent the stone formation. That means, suppose a patient is suffering from the calcium oxalate stone, okay, and obviously pH will be acidic, okay, and you found the composition later on by a stone analysis. And for the prevention, what you can do now is, we can prescribe some medication that can alter the pH of urine to the alkaline, like we most commonly use the citrate, oral citrate. Okay, so that the oral citrate make the urine more alkaline and prevent the uric acid stone formation or oxalate stone formation. That's why this knowledge is very crucial. That's why we always do a pH, and we don't do a pH separately. You just order for urine routine, the pH will come, but you have to focus on these informations. Okay. Crystals, these crystals are seen under microscope, and the shapes are very catchy thing, so it is very commonly asked in exam, in MCQs. That's why you need to understand remember the shapes. Okay, uh, so for exam point of view, please remember these shapes. Okay. And culture and sensitivity. See, culture and sensitivity, I've already told you that UTI is often associated with stone, and stone is caused by UTI. So, invariably, and we always need a sterile urine to do any intervention in the urinary tract, obviously in stone disease as well. So, we need to do a urine routine and culture in the case of suspected stone disease, to know the bacteria, and to know the antibiotic, and we can such that we can make the urine sterile for treatment, for prevention, and as well as for the preparing the patient for the surgery. That's what it is essential. Renal function test, we have already discussed about renal function test. Okay, the most common renal function test that we do are serum creatinine, blood urea nitrogen, and electrolytes. Okay, and you also know that creatinine can be used by a formula. Okay, and we can calculate the GFR. So these are done every time. But there's a condition. Sometime we need to do a DTP renogram. This is not done routinely. The DTP renogram help us help us to identify the function of a kidney separately. That is, it can show you the differential function of kidney. That is, how much the right kidney is functioning and how much left kidney is functioning. We don't need this information all the time for stone disease, but Sometime we need to know. For example, patient have a stone in the kidney, okay, and and the stone is very fairly large stone, okay, and you are thinking, and even the cortex is become very thin, okay, thin due to the stone, due to hydronephrosis. And now you're not sure what to do. Should you remove the stone, or you should remove the stone along with the kidney, okay, nephrectomy. For that decision, what we do is we go for a DTP renogram. And whenever the DTP renogram function comes as, if the function is less than 10 percentage in DTP renogram in compared to the opposite kidney, then we rather remove the kidney along with the stone, okay. But if the function is well, good enough, then more than 10% is, then we only remove the stone and preserve the kidney. In that scenario, this DTP renogram will help us to manage. But normally we don't do the DTP renogram for the stone disease. Now, plain X-ray QB, most of the stones are radiopaque, either poorly radiopaque or normal radiopaque. Okay, most of the patient, most of the stones are radiopaque, 90%. See here, there is a radiopaque shadow you can see here. Okay, how to count. So this is the sacrum. So this is number 5, 4, third. So what you can say is that there is a radiopaque shadow at the lumbar third vertebra on the right side, right renal region. Okay, single radiopaque shadow is there. Okay, so this might be the case of stone in the right kidney. But this type of radiopaque shadow can be caused by other cause as well. Like this, why not this is the case of gallstone, because gallbladder also is found exactly along that point. Why not this is the case of a calcified 12th rib tip? Why not this is the case of a calcified lymph node or calcified vein or any foreign body inside the abdomen? So, whenever you see a radiopaque shadow in plain X-ray, it may be due to stone or it may be due to other cause as well. That's why we need to do further investigations to differentiate whether it is inside the kidney or not. Okay, can do that. See another plain X-ray QB. What you can see over here is a plain X-ray QB showing you the bilateral multiple branching radiopaque shadow extending from 4, 3, 2, 1. So from the lumbar 1 to lumbar 4 level. Okay, so this is the case of bilateral stag on stone. So you can easily see in the plain X-ray QB. There is another radiopaque shadow at the level of lumbar. This is again 5, 4. So there's a elongated radiopaque shadow along the left paravertebral region at the level of number 4 vertebra. So this is most probably upper aortic stone. We are not sure because plain X-ray we cannot say the exact location of the stone. We guess according to the anatomical knowledge. To know the exact site, we should do further investigation, like either we go for IBU or go for a non-contrast CT scan to know the site. So see, this is an XAQB again. You can see there's a smooth, round radiopaque shadow inside the pelvis. Okay, so this is most probably the case of bladder stone. So we can see these type of stones in our normal XAQB. Okay, we can see that. Now let us see about ultrasonogram of QB region. Okay, this is a very good test because ultrasonogram QB is very safe because it's lack of radiation, no radiation at all, and we can reproduce the test. That is, we can do repeatedly because we don't have any radiation, and it is inexpensive in compared to CT scan, and it is really inexpensive. Okay, so for that, how we can describe the stone? The stone is seen as a bright echogenic structure producing a casting shadow. Let me show you one thing here. This is the bright structure producing the shadow. Producing the shadow. The outline of kidney is not that well here, might be due to the multiple stone or branching stone. Okay, you can guess over here. You can see another picture. This is the outline of kidney. You can see, okay. You can see the corticomedullary area. This is the corticomedullary area over here, cortex, okay, kidney. And you can see here there is a bright echoing structure producing the posterior shadow. So you can see here, this is the renal stone, that is also renal stone. So the ultrasonogram not only give us idea about the stone, but also it give us idea about the condition of the kidney. In the picture B, you can see the corticomedullary area is very good, very thick. So the health is okay. And also we know about the opposite kidney, because sometimes the patient might have only one kidney or maybe some other anomaly as well. And also this gives us idea about the dilatation of the pelvic calcium system. And if you go down, then it can also give us idea about the bladder and the prostate, which are essential for the bladder stone. So ultrasonogram is a very good test, but the problem is ultrasonogram is not a good test for ureteric stone, because it cannot locate the stone in ureter. It can give us an indirect imaging, but indirect idea, but cannot show us stone. Okay, as it can show the stone in the kidney and the bladder. And one more advantage of the ultrasonogram is it can show you the both radio opaque as well as radiolucent stones. That's why it is a great advantage. Okay, you can see this is the bladder outline. You can see over there bladder, and centrally this is black because of urine. You can see radio opaque shadows. Sorry, not the radio opaque shadow, hypoechoic shadow there, producing the posterior acoustic shadow. So this is a very clean cut picture of the stone. The bright echoing structure producing posterior acoustic shadow, a black shadow. This is the stone in the bladder. So regarding the uh, ureter, what we can see for the ureter is, see over here, this is the outline of a kidney. Okay, outline of kidney. You can see this is the pelvis outline. What you can see here, the central part is black. We all know that normal kidney, the center should be always white, fatty sinus. But here you can easily see the black area. That is this is a hydronephrosis. Okay, and see the corticomedullary area. The thickness is still maintained. Okay, so this is the case of hydronephrosis. Suppose a patient came to you, a 20 years old male, complaining of the left flank pain with radiation downward and with hematuria, and you ordered for ultrasonogram and you found like this. Okay, so you cannot see the stone, but what you can see is the clinical picture is very related to the stone, and you can see the hydronephrosis. So what we can guess is the stone might be somewhere in the ureter, because you know that ureter is especially upper ureter, that's why it is a hydronephrosis. Okay, maybe the stone might be somewhere near the PUJ in the upper ureter, such that it can cause the dilatation of the pelvic ulcer system. And actually the other picture here also, you can see the outline of the kidney. Always try to find the outline first. Okay, and then try to find the central part. Here also central part should be actually whitish in color due to sinus fat, but you can see the clear outline of the pelvis. Whenever you see a clear outline of pelvis, it is not normal. So this is the dilated pelvis. Okay, also you can see the dilated ureter over here. So here the stone might be somewhere in the ureter. Okay, not exactly at the pusae, maybe somewhere near below, such that it is causing the maybe somewhere here. Okay, maybe somewhere here, causing the obstruction and leading to hydroureter nephrosis. So ultrasonogram can give you an indirect idea about the stone, but cannot exactly show the stone in the ureter. That is some of the disadvantage or limitation of ultrasonogram, but still it can give you a lot of idea. Now IVU. See, IVU is intravenous urography. What we do in IVU is we inject a dye, a contrast media in the vein. Then before injecting the contrast media, we take one X-ray film known as control film. Then after giving contrast, contrast in IV, we take a series of the X-ray film within 1 minute, within 5 minutes, then within 15, 20 minutes, and so on, such that we can see the excretion in the kidney, then ureter, then the bladder, then the post void, everything. I've already taught you regarding IVU. Okay, so let me focus the use of IVU for stone disease. IVU can be done for a lot of disease, but I'll be focusing now on stone disease. Okay, so IBU can locate the stone, can give us idea about the size, and also it can give us idea about the hydronephrosis, opposite kidney as well. We all know that, and it also give a idea about the function of kidney. How I'll tell you, if the kidney is excreting dye, we say it is functioning. Okay, that's why it gives us idea about the functioning of the kidney. Whenever the kidney doesn't excrete the dye, that we can say this is a non-excreting kidney, and the renal damage is one of the cause of non-functional kidney, non-excreting kidney. Okay, so this will give us an idea about the functioning of kidney as well. Okay, so see, then why we use IVU for stone disease? Okay, we use IV for stone disease because it gives us exact location of stone, and it also gives us idea about the opposite kidney and other condition as well. If you see over here in the right side image, what you can see, there's a very faint radiopaque shadow um, in the renal area. You can see the outline. Okay, and this is a control film, and after 20 or 30-minute film in the beam image B, you can see the that radiopaque shadow is corresponds to the lower calyx and the pelvis. So by knowing this, what we can do is we can plan for the management. So this is a fairly large stone. For this type of stone in the lower calyx and the pelvis, what we can do is we can go for a PCNL from here, or we can go for the open surgery like nephrolithotomy or like that. Okay, so see the exact location and the size and the condition of opposite kidney give us idea how to plan. You can see over here the opposite kidney is very well functioning. See the upper calyx, okay, the mid and lower calyx. These are very pelvis is found, the uterus is seen. We can guess yes, the opposite kidney is good, fine, no problem, and this kidney contains a fairly large stone. So we can plan for the approach of the surgery. And always remember that whenever you plan for the IVU, the three things you must remember. That is, don't do IVU whenever the patient has a raised serum creatinine over 1.5 milligram per deciliter, because this indicates the impaired kidney. And impaired kidney, if you use a contrast medium, then it increases the damage of kidney. Whenever the patient has a history of contrast allergy, then we don't use the contrast because he had a history of contrast allergy, right? So it may lead to a severe anaphylactic shock during the procedure. And obviously, pregnancy is contraindicated because during IVU we take multiple image, and that add on the radiation hazard to the fetus. That's why we don't do that. So let us see some of the IVU. See in this picture, you can see the radiopaque shadow at the lumbar 543 lumbar third vertebra. Okay, so you can just say, yeah, it is at lumbar third vertebra on the right side. It might be inside the kidney. So how to know exact size? If you do IVU, then let us see the around 20 or 30 minutes film of IVU. Okay, but you can see over here the stone that is at the lumbar third vertebra on the right side corresponds to the lower calyx and the pelvis of the right kidney. We can exactly say the stone is inside the kidney, and we can exactly say the stone is at the lower calyx and in the pelvis. So for this is fairly large, around maybe 2 centimeter around, maybe. Okay. For this case, what we can plan is either we can go for a PCN from here, okay, or what you can do is you can go for a RIRS from ureter and break the stone. So see, you can plan the management. See this eye view, this is very interesting eye view. Okay, you can see over here, you can see in this eye view, in the control film, you can see a fairly large, okay, radiopaque shadow, single one, at the level of number 5, number 4, number 3, number 2, number 3, number 2 level. Okay, it's very large. And in the subsequent image is that after 5 minute film, what you can see at the right side, you can see the kidneys started excreting the dye. So right is okay, fine. You can see there's no dilatation, nothing is there. But in the left side, what you can see is we can see the very faint outline of kidney. Okay, but we cannot see the calcium system. Okay, let us follow the image further. And 30-minute film, what we can see over here in the right side, yeah, everything is okay, fine. You can follow the ureter, you can follow up to the bladder. The bladder is filled over here, but you cannot see any such image along the left side. No ureter line is seen, no calcium system is seen. That is, at the 30-minute, we can see the left kidney is not excreting. And then we have waited for till 2 hours, okay, and what you can see in this after 2 hours, that still the left side we cannot see any excretion. So this is the case of non-excreting kidney in the left side with stone. So obviously, whenever there is a non-excreting kidney on the left side with stone, this might be due to due to the stone. There might be the obstruction. Obstruction may lead to the hydronephrosis. That may lead to the damage of the kidney, and that's why kidney is not functioning. So in this scenario, what to do is we further do a DTP renogram and try to identify the function of this kidney. And if the function is less than 10%, then better to do nephrectomy, remove the kidney and the stone. If the size is, if the function is more than 10%, then we can save the kidney. So, so I will give us a lot of idea, and we can plan the further investigation according to the IVU as well. Okay. So see, IVU is also essential for the ureteric stone. So you can see this is around 25-30 minute film where you can clearly see uh, two kidney with the ureter and the bladder. So you can see, I'll just show you this one. Okay, this is the kidney in the right side. You can see the calcium system. You can see pelvis, and follow this one. You can go downward and go up to the bladder. Similarly, you can do on the left side as well. Okay. So see, this is the pelvis of the kidney, and this is the ureter. So the junction is known as pelvic ureteric junction, a junction between the pelvis and the ureter. So this is the beginning point of ureter. And see over here, the junction at the bladder is known as vesico-ureteric junction, VUJ. This is how the ureter length is there. In an average in adult, it is around 25 centimeter long. So we can divide this ureter radiologically into three parts: upper or proximal, mid, and distal or lower part. Three parts. How? Before knowing that, you should know where is the sacroiliac joint. So this is the ileum of the hip bone. You can see over here. Okay, this is the ala of sacrum. So you can see clearly this is the sacroiliac joint. Okay, so now if you know the sacroiliac joint, now you can clearly divide the ureter. So the part of ureter that is exactly lying at the level of sacroiliac joint, it known as mid ureter. Okay, the part of ureter lying above the upper part of sacroiliac joint, it known as upper ureter or proximal ureter. The part of ureter lying below the sacroiliac joint is known as distal ureter or lower ureter. So we can classify. Then you may say, why we need to do that? Because the treatment of the stone disease in the upper, mid, and lower is different because of the approach. Okay? That's why we should know the exact location, upper, mid, or lower. Otherwise, we cannot plan the surgery. See this one? This is the control film of eye view. What you can see here is a very large, elongated radiopaque shadow here, okay, which is occupying the lumbar fourth, fifth, and sacral first vertebra along the right side. So as it is elongated and lying along the line of ureter, we can guess it is a case of right ureteric stone. So we can see in that control film. Let us see the 25-minute film of eye view. What we can see over here is see the stone with the stone. So I think this is up to this one, the stone, right? Okay. You can see above the stone, the ureter is dilated, and also the calyx is dilated. Compared to the left side, it is dilated, and you cannot see any dye going downward. No dye is seen going downward. Okay, no contrast is seen going downward. So, with this all knowledge, so no dye is seen over here. No dye is going downward. So with this knowledge, what we can say that the stone is lying at the upper and part of the mid ureter with hydroureteronephrosis, that is dilated ureter and kidney, and it is impacted because no dye is coming down. So this much knowledge you can get from the eye view. And why this knowledge is important? Because impacted stone, very large stone, this need a very early intervention because of the obstruction. And this type of stone is basically, it can easily be managed by open surgery than the endoscopic surgery. Okay, you can go for open or laparoscopic. Open is better. Open urolithotomy is the better option for this patient due to the large stone. Okay, so you can plan the surgery. Now comes the most important part: CT scan. CT scan QB. Okay, this is the gold standard, or the imaging of choice. So CT scan, we can do CT scan non-contrast and contrast. The best one is non-contrast CT scan, because non-contrast means we are not giving any contrast, IV or oral. See, whenever we give a contrast, the contrast looks white, and the stone are also white. That's why they look confusing for the diagnosis. That's why the non-contrast is enough for the diagnosis, and this is the gold standard or imaging of choice. Okay, and also it also helps to differentiate the cause of the acute pain during the emergency situation. Suppose you are working at the emergency department, and a patient, a young patient, 20-25 years old, male or female, male, okay, came to you complaining of pain over here. Okay, see, along the right iliac fossa, like this. Okay, if you say I have pain over this area, then obviously, and he's not saying nothing, no pain and nausea, vomiting, and no other symptoms, and any pain along this area like that, what are the cause? You may think it's a case of acute appendicitis. You might think this is the case of a ureteric stone, or maybe obstruction of intestine, something like that. So at the emergency, we don't have luxury to investigate sequentially. So at that time, we have to think one investigation that's the best for everything. In that scenario, obviously, non-contrast CT scan would be better, because it not only show you the stone, but also it can differentiate with the other cause like appendicitis, or maybe the obstruction or something else. So this is very good. Okay, so it is indicated that whenever there is an acute pain suspecting a renal colic or ureteric colic, better do non-contrast CT scan than doing the other investigations. So okay, fine. Then after that, what are the advantages of doing non-contrast CT scan over other investigation that other investigation cannot give us idea? That is, okay, you can locate fine the size is more accurately shown by the CT scan. The density, it is important. Density means hardness of stone, okay, which can be measured by CT scan as a Hounsfield unit. And if the density or the hardness is more than 1000 Hounsfield unit, it is regarded as a hard stone. So why we need to know that? Because some treatment we cannot do whenever the stone is hard. For example, shock wave lithotripsy or extracorporeal shock wave lithotripsy. breaking the stone by the shockwave from outside. It cannot be applied when the stone is hard, that is more than 1000 ounce freely. And this is very important for the management. Skin to stone distance. Okay, suppose this is the CT scan over here, kidney. Okay, this is stone. The CT scan can easily measure the distance of stone from the skin to the uh, stone of distance between the skin and stone. Why this is required? Because again, if the distance is more, then the shock wave cannot be applied. So this knowledge are can only be shown by the CT scan. And one more thing, see, uh, the kidney is surrounded by a lot of organs. Okay, mainly the large intestine. Okay, sometime what happens is the large intestine is normally found along the anterior surface of kidney. Sometimes the large intestine may be found behind the kidney. It's very rare, but it may be found. And while puncturing the kidney from behind, sometimes we may injure the intestine, which cannot be seen by eye view, but can be shown by the CT scan. So all this additional information, which are essential for the pinpoint management, can be obtained from the CT scan. Okay. And also it can diagnose the radiolucent stone. I've already told you this thing. And as it is non-contrast CT scan, uh, there won't be any radiation. Sorry, there won't be any uh, contrast hazard for the patient because we are not using any contrast. That's why it is indicated for the patient having the renal impairment, that is more than 1.5 gram per deciliter of creatinine. We can use this test very safely. Obviously, it might have some disadvantage. The disadvantage is the radiation is more than the IVU and other X-ray. So it is the radiation hazard is more. That's why it is not indicated for the pregnant ladies. And as we are not using any contrast medium, we cannot say the functional status of kidney because we cannot say whether the kidney is excreting or not. So these are some disadvantages. Still, CT scan, non-contrast CT scan is the best investigation for stone disease, not only for diagnosis, but also for differentiating with other cause as well as detailed planning for the surgery. Contrast CT scan we can do whenever there is a very complicated situation like duplex kidney and so on. When we need a detailed outline of the urinary system, that time we can add the non-contrast CT scan with non-contrast CT scan. But normally, non-contrast CT scan is enough. Let us see some of the example. This is an axial view. Whenever you see a round image, it is an axial view. It is non-contrast. Why? Because see the aorta is not gray, not getting any contrast. See the kidney parenchyma is gray, not getting any contrast. So this is not an IV. There is no IV contrast given. And remember one thing: whenever you see a white structure or a hyper dense structure in non-contrast CT scan, it is mostly stone. That is calcification. That is stone. So here you can see there is a bilateral hyperdense structure at the renal pelvis. And so this is the case of bilateral renal stone occupying the renal pelvis. You can see again there is another picture. This is also non-contrast because you can see the aorta is gray, okay, and the kidney parenchyma is gray. So we haven't given any IV contrast. And any not radio effect, any hyperdense shadow, uh, that is white hyperdense shadow inside the kidney. Obviously, it's a case of stone where the left side. Okay, so hyperdense structure at the pelvis of left kidney is the left renal stone. You can see that. See, this is a coronal view. You can see the coronal view means you can see upside entire abdomen. This is non-contrast because see still the kidney parenchyma is not white. That is, there is no dye over there. You can see there is a hypertensive structure with the dilated ureter just above it, okay, including the dilated pelvis calyceal system. So you can see here, and this stone is above this line, that is above sacroiliac joint. So what you can see, there is a hypertensive structure at the upper ureter associated with hydroureteral nephrosis. So this is the case of left upper ureteric stone with hydroureteral nephrosis. hydronephrosis. SDUN means hydronephrosis. Okay. See, this is the axial view of a pelvis where you can see the bladder outline. Okay, and you can see a very hyperdense structure inside the bladder. This is the bladder stone. These are the bones of the pelvis, basically the along the hip joint. Okay, fine. So see, the CT scan is very good. Okay, not only for diagnosis but also for other important points that I have already explained. So let us see some special situation. Now the question arises, okay, fine, then what to do whenever the patient, suppose the patient is a pediatric patient. So what investigation is very good for the pediatric patient? So pediatric patient, whatever we think is, we think about the radiation, right? So because the growing epiphysis may be damaged by the radiation, that's why the first choice of investigation would be ultrasonogram QB. Okay, but we can do XAQB as well. And if you want to do a CT scan for the detailing knowledge, then we can go for a low dose CT scan, not the normal dose CT scan. Low dose non-contrast CT scan is around 4 to 5 times less radiation hazard than the normal dose CT scan. We can do like that. Okay. Similarly, in the pregnant lady, we all know that pregnancy is a well, we cannot do the radiation thing. So the first investigation is always ultrasound QB, and we can go for a detailed imaging by MRI. MRI is the second line. Okay, and if we need the detail, then we can go for some time. We can go for a low dose non-contrast CT scan. The radiation is very low, around 4 to 5 times low than the normal CT scan. So these are the European Urological Association guidelines for the investigation for children and pregnancy. So follow this one whenever you have a patient. Okay, best one is always ultrasonogram in these scenarios where the radiation is contraindicated. So after doing this all investigation, one more investigation I want to highlight now. So these investigations are actually not for the treatment. That is not for the surgical treatment or whatever you say. These investigations are special investigations which are done after the treatment of stone for the prevention part. Because whenever the patient has a stone, we know that within 10 years 35 to 75% chances they can make the stone again. So to prevent those recurrent stone formation, we have to do two investigations. One is known as stone analysis, other is metabolic analysis. Stone analysis is done in the lab after the removal of stone. That is, whenever we do a surgery or the stone comes out by itself, we collect the stone and send to the lab, and the lab will do the test by X-ray diffraction technique or infrared spectroscopy technique. These are the technique they do it. Okay, and from that technique they will give us the exact composition of the stone. That stone might be calcium oxalate, that stone might be struvite, that stone might be uric acid. They can say it. And the European guideline says that each and every stone that is removed from the body should be analyzed. Should be analyzed. Okay. So whenever the patient, when you treat the patient and the stone comes out, then you have to send for the stone analysis to know the composition. And another one is metabolic analysis. So as I have already told you that there are a lot of metabolic disorders that occurs, right? Hypercalcemia, hypercalciuria, hyperoxaluria, hyper cystinuria, and then hyperuricosuriia or hypophosphaturia, sorry, hypocytituria. So in that cases, all those can be identified by a metabolic analysis. Okay. So metabolic analysis is a test where we do test in the urine and test in the blood. Okay. So urine, what we do is we collect the 24-hour urine. So we ask the patient to collect the urine from 8 a.m. today to 8 a.m. tomorrow and give all the collected urine in a jar to the lab. And they will do centrifuge and they will take a sample from that and they will identify. So we need a 5 things from that urine. That is calcium, uric acid, phosphate, citrate, oxalate from the urine. So I used to remember by CUP. Okay, so calcium uric acid phosphate, citrate, and oxalate. Okay, in the urine, 25 urine. In the blood, what we do is we test again same the first three, that is calcium, uric acid, phosphate inside the blood. Okay, calcium, uric acid, and phosphate. So these three in the blood and the same three plus oxalate and citrate inside the urine. We do that routinely. And whenever there is a hypercalcemia, excessive calcium, we always check for the parathyroid hormone, because we know that parathyroid hormone lead to hypercalcemia. Okay, so these are the basic tests. Okay, and we also do other electrolyte tests. Okay, but these are the thing. And the question is when to do same thing after removing the stone, not at the initial diagnosis. Then whom to do? For those patients who are at the higher risks of stone formation recurrence, that is, those who had a history of recurrent stone formation, those patients, who has a strong history of family history of stone disease, because I've already told you some diseases are genetics. Okay, some cause are genetics. And those who have a single kidney, because see, patient already have a single kidney. We don't want that kidney to form stone again. We don't want to operate in the kidney multiple times. We have a single kidney. That's what we want to prevent. And some of the stone composition like cysteine, uric acid, and struvite. In that case, also we do the metabolic analysis. The list is long. I've just given you the very few common to remember. Okay. So again, the stone analysis and metabolic analysis are not done at the first diagnosis. We do it after we treat it, stone is removed, then only we do the stone and metabolic analysis. Stone analysis is done for each and every patient. Metabolic analysis are done for those patients who are at risk, where we do 25 urine test and the blood test. Okay. So thank you for the patience listening of my lecture. This is the end of my lecture. I have used these books and the guidelines to make the lecture. Okay. And if you have anything that you want to ask, you can ask me uh, in the message box. Okay. Thank you for today. We'll continue the lecture later on. Thank you very much.